The other thing that has been characterized is there is a regulatory entity within our cells that's called the NLRP3 inflammasome. And this is basically like a master sergeant who oversees a platoon of inflammatory soldiers. And this regulates multiple downstream inflammatory pathways. And when this inflammasome comes together, it works. If it doesn't come together, it doesn't work. And beta-hydroxybutyrate blocks the assembly of the NLRP3 inflammasome. A study that was published by Jeff Volek's graduate student, Cassandra Forsyth, she got 3 or 4 papers out of this and then got her PhD. This paper is highly cited. I think it's been cited over 200 times since 2007. And basically what Cassandra and Jeff did was they recruited 40 people with metabolic syndrome, and half of them they gave a low-fat diet, restricted in calories to 1,500 calories per day. So metabolic syndrome includes obesity. These are people who would like to lose weight. So they recruited them and said, we're going to give you a really nice flavored, good, real food diet. And Dr. Zinn would be very happy with the fact that this is all real foods. We didn't use any highly processed foods, or almost none in putting it together. And they ate this, they were given this diet for 3 months. The other group were randomized to the ketogenic diet, but they gave them the freedom to eat as much as they want. And the reason why we did that is we know that when you take people like this and give them a well-formulated ketogenic diet, they undereat calories by about 1,000 calories per day. So these 2 groups were actually matched in caloric intake. One group was calorie restricted and one group was eating to satiety, ate about the same number of calories. And you'll notice in red at the bottom that the ones on the low-fat diet got 12 grams of saturated fat per day, and the ones on the high-fat diet got 3 times as much, 36 grams of saturated fat per day. What do you think is going to happen to their blood saturated fat levels? You know, you are what you eat. They're eating 3 times as much saturated fat. We'll come back to that. 2 more slides. Weight loss. The group that got the ketogenic diet lost twice as much weight as the group that followed the control diet. Ostensibly, they were eating the same number of calories, but these were outpatients, and they had the opportunity to eat other stuff. So we don't know. You know, we did not have 24/7 cameras mounted on these people. Then the question is, how much of that is water? You know, when you go on a ketogenic diet, you lose quite a bit of body water. Well, you lose water associated with glycogen in muscles. But if you don't have edema, you're not going to lose that much more water. If you do, you're going to reduce your circulating volume and your cortisol level is going to go up. But the result was that when we did body composition with DEXA, dual X-ray absorptiometry, the group on the ketogenic diet, 1 kilogram of their 10 kilograms of weight loss was due to extra body water loss. And the other 9 kilograms was what they wanted to lose. And you notice that the range, the median weight loss in the ketogenic diet group, the bars coming down on the right-hand side there, the red bar there or line for the people on the ketogenic diet, the average value of weight loss was greater than the greatest weight loss in the other group. But the most important thing is these people were people with metabolic syndrome, and the components of metabolic syndrome are outlined in green there, and you can see that the red bars were dramatically better than the blue bars. The blue bars are being the low-fat diet, and the red bars are the ketogenic diet. And then the other really interesting thing on the far right-hand side, outlined in orange, is the blood triglyceride levels of saturated fat. So this is the fuel triglycerides circulating through your blood, and the ones who got the ketogenic diet with 36 grams of saturated fat had more than double the reduction in blood saturated fat. So if you have a little card that you carry with you, say, you are what you eat, tear it up. You are what you say from what you eat. And one of the resilient and robust metabolic characteristics of nutritional ketosis is you give the body the permission to burn at least twice as much fat as when they're not on a ketogenic diet. And that's whether they're at rest or exercise. And it clearly, one of the fats that the body prefers to burn when you give it permission to burn twice as much fat is saturated fat. It only hurts you if it builds up in your blood. If you're keto adapted, you can eat saturated fat. I won't say to abandon, but as a significant proportion of your fat coming from coconut oil, from animal fats, wherever, and you will burn it for fuel, turn it into CO2 and water, and contribute to global warming. But speaking about warming and inflammation, we measured 14 biomarkers, bioactive compounds associated with inflammation in these patients. It was a 3-month-long study, and of the 14, 7 of them came down significantly in the group, to a greater degree in the group on the ketogenic diet compared to the control diet. And those are the little alphabet salad here. But what I want to point out is, interestingly, over on the right-hand side, those are the column, in that column was the things that didn't come down, and one was white blood cell count and one was CRP. And it turns out that all these different keys on the keyboard don't respond in lockstep in the early phases of keto adaptation. And C-reactive protein in particular is one of the slow responders. So I've seen multiple papers of people doing well-done ketogenic diet studies, and they measure C-reactive protein and say, see, inflammation doesn't come down. You know? It's like, running a really, really fast quarter mile, but you never get the gold cup at the 1 mile mark in a 1 mile race. You got to run the whole race. It takes longer than 3 months for CRP to respond to this type of intervention. So cutting to the chase, more recently, the study we did with Dr. Sarah Hallberg in Indiana, we've completed 5 years, by the way, and she survived through the final patient visits at the 5-year time point. And that was part of her commitment to this process. So we recruited 262 people. Actually, we recruited close to 500. There was about 100 people in a non-randomized parallel usual care group. And then of almost 400 people total, 262 had diabetes, and the remainder of them had prediabetes. So focusing on the people with diabetes, they were about 2/3 female, average age 54, very overweight, average BMI was 41, had lots of weight to lose. And importantly, the average duration of time since diagnosis was over 8 years. These are not new onset, early stage people with diabetes. Some of these people had diabetes for 20 years. The majority of them were on 2 or more drugs, metformin plus something else, and some of them were on multiple drugs. And they were managed through basically a remote continuous care app across the full 2 years of the study. And the patients had access to a coach and to a physician, in the case of the study, to Dr. Hallberg, on a continuous basis, 7 days a week. They could reach out through the app and get in contact with someone. They got most of their education through video and printed materials. They monitored their blood glucose and their blood ketones. They stood on the scale every day. They couldn't misreport their weight because it was a cell phone connected scale. The only way you could mess with it is hold on to a bunch of helium balloons while standing on the scale. And these were a very committed group of people because all of them had met and interacted with Dr. Hallberg, and her ability to connect with people and convey the sense of benefit to them and the sense of the mission was just absolutely incredible for this study. This is an older slide. We've published, at this point, 11 papers from this one study, but these are the papers that demonstrated 1-year and 2-year data on diabetes and also cardiovascular risk. I'll focus just on the 2-year data. So this is a paper published in Frontiers of Endocrinology, and we presented it at Obesity Week in 2018, so it's not brand new. The blue line across the top shows retention in the study, and you can see at 1 year we had 83% retention in the people with type 2 diabetes, and 2 years, 74% retention. And I'm not bragging, you can go look. In lifestyle studies, maintaining half the people in a study at 1 year is considered good. And having this level of retention at 2 years is remarkable. And then the embedded graph there on the lower left-hand side shows the daily blood ketones in patients over a 1 year period of time. And you can see that out to 8 months of that 1 year time frame, the group mean value for beta-hydroxybutyrate was 0.5 millimolar. So people who tell you that patients can't maintain this, wrong. People can maintain it. You just have to give them permission to do it and proper information in terms of how to do it, and it can be done. At 2 years, our mean value was down to about 0.3, but it was still statistically significantly above their baseline value. So the ketogenic diets can be maintained. They're really hard to do, and it takes a really robust support system to allow the majority of people to do this. When they did that, the blue line here shows the weight loss at 1 year was about 35 pounds of weight loss, and that's with the 80+% retention. And at 2 years, there was a 5-pound weight regain, but they still maintained a 30-pound weight loss, which is truly remarkable among non-drug assisted or surgery assisted lifestyle interventions. And then the usual care group, you can see that their weight went up over the 2-year period of time. And on the right-hand side, you can see that hemoglobin A1C dropped about 1.2 units at 1 year, and we maintained a 0.9 unit reduction. And 0.9 unit reduction is the same or more than you would expect from one full, powerful type 2 diabetes intervention drug. The other thing that occurred in the first over this time period is we reduced and maintained the patients off more than half of their diabetes medications. And for the people who started on insulin, half of them stopped their insulin in the first month. And you heard Dr. Penny Fig Tree mention that, and she also, and I was delighted to hear her say that this is not an easy thing to do and to monitor. And the way that we can do this safely in a very large number of people, and we now have tens of thousands of people in whom we're doing this, is because we have the app and they have continuous access to a trained physician and working with a trained coach. This is now a graph of the 12 different biomarkers that are associated with coronary disease risk that has been formally proposed as a way of measuring long-term disease risk, 10-year disease risk. The overall disease score is reduced by 12%. The only fly in the ointment is there in the middle, that downward pointing arrow with a red core is LDL cholesterol. And if blue goes up, it's because the ketogenic diet improved it. If blue goes down, ketogenic diet made it worse. On average, LDL went up, but the thing's pointing down there. LDL went up about 10%, 9% in this population. But the HDL cholesterol went up markedly. So pretty much everything else improved. And the result is that this calculated disease score, where we don't look at just one key on the keyboard, but we look at the whole keyboard, is getting better. Cutting to the chase, inflammation. We measured 16 biomarkers. 2 of them were not significant. The one on the right, where it goes up, which is VCAM1, is not actually a risk, is not associated with diabetes risk. And over on the left-hand side, ICAM1 was reduced at 1 year in blue and further reduced at 2 years in red, but it wasn't statistically significant. All the other reductions were significant. If you look at the far left-hand side, the well-formulated ketogenic diet at 1 year reduced C-reactive protein by over 30%. And it wasn't significantly reduced further, but at 2 years we had an even greater reduction in CRP. But the important thing is we changed the level of inflammatory stimulus across the whole keyboard. So there was a balanced effect of this, but realize we've evolved with this molecule since the liver was invented. This is an evolutionarily long-lasting thing that through evolution the body has figured out, how do we play this music where we respond when necessary to challenges like inflammation or like infection or trauma, and then how do we shut it back down into the normal resting range when it's not doing us harm, and clearly we're doing this in a balanced manner. So coming back to this picture here, there are multiple roles for this molecule. As you can guess, there are people who are trying to figure out how we get this molecule into people without having to go on a ketogenic diet. And the folks at the Buck Institute are working on a one of a class of compounds, one of a class of compounds called ketoesters, where you're not eating ketone salts, but you're actually getting these where you don't have to have a lot of sodium and potassium and magnesium. Those are good things to take in moderation. But if you want to get 75 or 100 grams of ketones into someone, you can't give them that much as ketone salts. So they're working on these things called ketone esters, where exogenous ketones may be able to achieve some of these effects. And as I mentioned, when they infused beta-hydroxybutyrate into mice for one day, they got a measurable effect on gene expression. So don't discount exogenous ketones. But my liver probably makes 75 to 100 grams of ketones per day. Currently, ketones of various forms probably cost the US about $1 per gram. So my liver is making $75 to $100 worth of good stuff every day, and all I have to do is eat good food. So in terms of other inflammatory diseases, this is just a wish list. If you say, oh, Steve Phinney says it works for multiple sclerosis and depression and arthritis and asthma, we have lots of anecdotes of that. I could have come up with 10 or 20 cases. But until we study it in a prospective, randomized way and demonstrate that it is robust, that it'll work for a long period of time, and that it's safe, this is our wish list of what we want to do. And my conclusion is there's no drug in chronic use that can deliver these potent effects safely. This is a truly unique tool. And I think we came up with an interesting acronym. We call it NOODLE, and that's not a carbohydrate food. It's NEWLE, it's nutrients with drug-like effects. And this is the poster child for that concept. The diet is potent and both broadly based. It requires giving people adequate support and information, and that's not easy for people to do. Not everybody can do it. And there are times in people's lives when they're ready for change and times when they're not. So it's not something you tell people, you need to do this now. You say, this is available when you're ready. We're here for you. And then, as I mentioned, we have lots of future targets to study. And with that, I'll brag about the fact that once upon a time I climbed a mountain that was 14,000 feet high with no carbs. And thank you.